Most of endometriosis is usually found around your uterus, your womb, which would mean around the fallopian tube, around your ovary, which is where your eggs are, on the muscle itself, because remember, you're not having a period from the muscle, you're having a period from the cavity. It feels like barbed wire pain. So during your periods, it feels like shards of barbed wire are sort of ripping through you. Yes.
We're going to help you understand everything about endometriosis. And of course, since I'm not the specialist, I'm here with an obstetrician gynecologist, Dr. Swabra, who is going to help us understand what exactly endometriosis is.
Endometriosis is basically a condition that affects 1 in 10 women, and it's where the uterine lining that usually has a menstrual flow every month is found elsewhere other than where it's supposed to be found. And so most of endometriosis is usually found around your uterus, your womb, which would mean around the fallopian tube, around your ovary, which is where your eggs are, on the muscle itself, because remember, you're not having a period from the muscle, you're having a period from the cavity, behind the uterus, where the rectum is, and in front of the uterus, where the bladder is. So those are the common places where endometriosis is found. But it can also be found in far off places, so not near your womb, but far off places being the lungs, the brain, and some other women around the abdominal area.
And speaking of the signs, and of course, a painful period, as you put it, that is one of the signs. Of course, you prove that if it's one of the signs,
Yes.
but that could be one of the signs or one of the things that people know or associate it with endometriosis.
Exactly.
So how does it present itself?
So endometriosis has no particular face, and we say endometriosis has a different face in different people. So it could come as painful periods, just as I've alluded, in that every period is just catastrophically painful. It could also come as irregular bleeding, prolonged bleeding, heavy bleeding, and that is just around the womb area. It could also come with bleeding when you're passing stool, bleeding when you're peeing, if you have blood endometriosis. We have endometriosis in other areas, for example, in the lungs. So every time you have a period, you're also coughing up blood. It could also be endometriosis in the brain. Every time you have a period, you have sort of a mini seizure or what we call an epileptic attack. So it depends on where it is found and then how extensive the disease process is. Exactly.
Okay, and speaking of painful periods, how painful or what is the severity of the pain that you're speaking about?
If we're to put the pain on a pain scale of 1 to 10, people have different pain thresholds. So there's a woman who will say it's a 3 and another who will say it's a 15 out of 10. But at least the common description amongst many women is it feels like barbed wire pain. So during your periods, it feels like shards of barbed wire are sort of ripping through you. Yes.
Okay. And in terms of age, is it a factor? Like, is it a risk factor in terms of maybe the young are affected more or the older women are affected more?
Endometriosis should ideally start with the onset of your period. So definitely, if I was to diagnose it, I would probably diagnose it at the young girl who's having her period as her period start. The thing is, every time a young girl tells you she has painful periods, what do you tell her? Ni kawaida, it's common, and it will pass. Exactly. So that is why we usually don't quite diagnose. But ideally, it is much more common in the younger ones because that's when the period is started. By the time you're catching it in the older population, it is a much more progressed disease process. Yeah.
Any other risk factors other than age?
Yeah. So family predisposition. If there is a family member that has endometriosis, chances will be high that probably what you're presenting with as pain may also be endometriosis. So when you're talking about the risk factors, then we'd also have to link in what are the predisposing theories to endometriosis. So there's what we call the retrograde menstruation, and that is why you cannot talk of endometriosis before a period comes in. So every time you would have a period, especially this being the area where the period is flowing down, that some of it would spill over backwards through the tubes, and that period will contain endometriotic cells. And so these will implant themselves around the surrounding organs. So that is retrograde theory. Of course, black women are more affected than white women. It's the estrogen predisposition. and basically familial predisposition. And there is also a genetic factor in that it is postulated that some genes are carried that carry the endometriosis condition. Yes.
All right. And now, when a patient comes to you, or a woman comes to you, or a girl comes to you, how do you tell that they have endometriosis?
The clinical symptoms and the signs should be enough to trigger your suspicion. So she's had a very painful period, heavy period. Your index for suspicion should go up. So of course you take the history being you just ask a few questions that would lead to you suspecting it. And then of course you work her up. Work her up meaning now you do your tests. Of course the first test we usually have access to is the ultrasound scan. I usually say in the hands of a good sonographer, diagnosis can be made. But sometimes the scan can miss endometriosis. And so the next modality of diagnosis, other than the ultrasound, pelvic ultrasound scan, is the MRI pelvis. And so you do your MRI, and most of the time it picks, and sometimes it doesn't pick. And there is finally what we call laparoscopy. And we call laparoscopy the gold standard of endometriosis diagnosis, in that I am putting a camera in your womb and around your abdominal area, and I'm seeing for myself if there are endometriosis lesions. So those three modalities are the most commonly used. But to add also, for example, if you have lung endometriosis, a chest x-ray would also be used, simply because where the disease is manifesting, you may do a diagnostic modality for that case. Bladder, you may want to do a cystoscopy, put a camera in the bladder so that you see for yourself. Brain endometriosis, you may want to do a CT scan, okay, an MRI overhead, so that you see endometriosis for yourself. Exactly.
All right. And speaking of periods, just to clear the air,
Yes.
does it mean that all painful periods are endometriosis?
No. Your index for suspicion should be triggered with painful periods. You should think of it as one of a diagnosis. But there are myriad of other causes that could, predispose to painful periods. Fibroids, polyps, ovarian cysts, just normally adenomyosis. There are so many things that could trigger painful period. So even when I'm doing all these modalities, it is important to note that when you're doing a diagnostic test, it is to narrow in on the actual cause, to rule out other potential causes, and also determine the stage or seriousness of the disease. So it does three things: make a diagnosis, rule out any other culprit, and determine where are we now, how bad is it. Exactly.
All right. And now, after looking at the diagnosis, let us now look at the a treatment of this particular endometriosis. You're a surgeon. You've, of course, undertaken a number of endometriosis surgeries, that is. So what does the treatment plan look like after you've diagnosed a woman with endometriosis?
Remember when you said endometriosis wears a different face with every patient. And so not every patient will come in seeking the same thing. And not every patient will come in with a disease looking exactly the same. Some patients who have, for example, fallopian tube endometriosis will come in with blocked tubes, and all they're looking for is fertility. So actually my first meeting with them will be, you have blocked tubes, I want to get you pregnant. So probably my instinct is to open the tubes as I take care of endometriosis. There's a young girl who's 16 years old. She's not thinking about childbirth. She's just thinking about pain. So even as I go for surgery, my instinct is not to fix anything or to open any tubes. It is just simply to alleviate her pain. So surgery is one of the treatment modalities. And with surgery, you usually keep an open mind. But most importantly, you have to be a qualified endometriotic surgeon. Why I'm saying that is endometriosis surgery is not kawaida surgery like any other surgery. It takes a little bit of finesse. And in this Mombasa of ours, I think we have one endometriotic surgeon, Dr. Mlatia. I am not one. Okay. In Nairobi, we have several, but of note, I will speak of Dr. John Njagi and Dr. Patel. Okay. That is number one. Number two, it is a multidisciplinary approach. Why? If endometriosis can be found in the rectum doesn't belong to the gyne. So what am I doing operating on the rectum? So in as much as I know it is my endometriosis that has caused that lesion there, even as I go to operate, since I'm touching other people's things, I'd rather be with the other person. So a surgeon should be on board. A urologist can be on board. A neurosurgeon can be on board. A chest surgeon can be on board. So it's a multidisciplinary approach. So that is just surgical management. Surgical management is also supported heavily with medical management. That even after doing surgery, trying to remove as much of endometriosis as possible, you may want to follow up with drugs that sort of suppress some hormones that make the endometriosis a bit silenced. Exactly.
All right, and as you explained, you spoke of fertility.
Yes, please.
So, what impact does endometriosis now have to this woman who has been diagnosed?
So endometriosis affects fertility in several ways. I'll highlight two. Number one, actually three. Blocked tubes. It is the commonest cause of blocked tubes in women. And most of the time we're going for blocked tubes, but we find that there are other lesions and we end up taking care of everything else. Number two, even with open tubes, or even if you decide you're doing IVF, if you have endometriosis, implantation is affected. So yes, their baby has been made. Yes, we've even made this baby through IVF. But to put this baby back in a womb that has endometriosis, the environment is hostile. And so most of the time, it can actually lead to recurrent miscarriages. Okay, so that impacts on my fertility. And then number three, pain. Pain is a big factor, and pain is a silent killer that no woman actually quite freely talks about, because if you're constantly in pain, you're describing your abdomen as being in a barbed wire kind of experience. How then will you have sex to have this baby? You understand? So most of the time, women who are coming in with painful sex, painful period, painful, most of the time, even the quality of your life, the quality of your sex life is already compromised, which already touches on my fertility. Yeah.
And how about the urge to have sex? Would you say could be one of the signs, other than the physical pain?
So most of the time, libido here is not quite affected because the hormones that cause your libido to either be up or down are not touched. But the experience of having, sexual relations with your partner is compromised because of the pain. So that may hold you back. Yeah.
Right. And in most cases, when women are undergoing their menstruation or the painful menses, let me say, many of them will go for painkillers, and especially for the pain that subsides with time. Yeah, then they just assume, then they wait again for the next month and all that. So, what's the danger of this?
You're suppressing, you're putting elastoplas on a wound that you have not quite healed. It is just a cover up. And I usually say that is the only reason why endometriosis diagnosis takes up to years. Actually, they said an average of diagnosis time is 10 years, simply because we keep imagining we can control the pain. Oh, it will get better when you have a child. It will get better when you get pregnant.
Yeah.
So all that waiting and sort of hoping and the fear of surgery is what keeps women back from actually seeking active treatment. So yes, you can have all the painkillers, but painkillers are symptomatic management and not thorough management. Yes.
Now, having talked about the treatment, or if it's the surgery and the management of all that, what is the success rate, or what happens to this patient now after the treatment?
So endometriosis prognosis is debatable, and I would say with proper surgery, you can expect proper treatment, complete treatment, and complete resolution of the symptoms. But we also have to entertain the fact that endometriosis is a progressive disease. Progressive in that the endometriosis you have now as a 14-year-old is not the same endometriosis you'll have as a 22-year-old. Things have morphed. It has affected slightly more structures. Things have gotten harsher inside there. Things are getting worse. So you would expect that the disease gets worse as time passes. But of course, with treatment and with proper surgery, we expect that there's absolute resorption of symptoms. Yeah.
Right, great. So, having spoken over the signs, of course, that this woman experiences, just speak to a woman outside there, maybe someone that is experiencing these signs, or someone that maybe knows of someone that is experiencing this, or just for the future, how to avoid this, probably so that we are not having a greater number of women, not just in Kenya, but worldwide, in terms of being affected by endometriosis.
There is no normal period pain. Let's not normalize pain. It is the normalization of pain that sort of leads to the delayed diagnosis. Number two, endometriosis is a condition like any other condition. It is not a death sentence. Treatment is there, modalities are there, just seek them out. It gets more expensive, and I mean time wise, medical wise, and even financially to treat it, the more you keep postponing it. So you suspect or you know that you have early disease, then it will make more sense for you to seek care early, because the repercussions of it touch on fertility, your psychological health, and so many other things which are impacted by the disease process. Your quality of life keeps deteriorating as you postpone treatment for endometriosis. So seek care immediately.
All right, so thank you so much, Daktari, for informing us, and most importantly, for educating us on matters to do with endometriosis. And I'm sure through this interview, we've saved at least, even if it's not
one
10,
person, exactly,
one woman.
Yes.
All right, so thank you so much to you two for watching. I hope that that was informative and, of course, educative to you. So just take note of the science that Daktari has spoken about, and please find help in case you're having any of those signs. Once again, asante sana. My name is Aida Muzati, a health and science journalist and a digital content creator on matters to do with your health and well-being. Thank you for watching. Don't forget to subscribe to my YouTube channel. Your Health Matters.